Okay, good afternoon, and thank you everyone for joining us for today's town hall on family planning and fertility in CF. Please note today's presentation is being recorded and will be shared on our chapter's YouTube channel. Please remember to keep your cameras off and your microphones muted during today's presentation. I'd like to thank everyone that submitted questions during the registration process. We'll do our best to cover these questions during the presentation, and we'll have time for Q&A at the end of our call. Now it is my pleasure to introduce our distinguished panelists. Dr. Tracy Kazmerski, Doctor of Medicine, Master of Science, and Assistant Professor of Pediatrics at UPMC Children's Hospital of Pittsburgh. Dr. Michelle Prickett, Associate Professor, Pulmonary and Critical Care Medicine, Associate Director, Adult Cystic Fibrosis Program, Medical Director of Respiratory Care at Northwestern Memorial Foundation and Northwestern University Feinberg School of Medicine. Last but not least, Alexander Philbrick, Doctor of Pharmacy and Board Certified Pharmacotherapy Specialist, Clinical Pharmacist, Specialty Pharmacy at Northwestern Medicine. Today, we will be sharing a historical overview of CF and family planning. We'll be addressing your reproductive goals. We'll present family building options, present some things to consider when preparing for parenthood, and the impact of CF medications pre and post pregnancy. So without further ado, I will turn it over to Dr. Kazmerski to get us started.
Thanks, David. So as you saw, I am funded by the Cystic Fibrosis Foundation and then by philanthropic support here at Children's Hospital Pittsburgh. I wanted to start and just remind everyone, not that this group needs to be reminded, but there are many organs that are affected by cystic fibrosis. Next slide. And specifically, there are many disease-specific reproductive manifestations of CF, including concerns around fertility, the menstrual cycle, and puberty. But as this group also knows, the life expectancy for people with cystic fibrosis continues to climb. And truly over half of individuals with CF in the United States are adults. Back in the 1980s, pregnancy was not considered possible for women with CF. However, as our therapies and care models improve, women are having increasingly successful pregnancies at higher and higher rates. So as you can see here, in 2019, we were up to 310 pregnancies among women with CF within the US. And this is still unofficial, but in 2020, there are over 600 pregnancies that have been reported among women with cystic fibrosis. And I wanted to start us here because I think this may be or may often be a common thought for people with CF. So as one woman said to me in a research interview a few years ago, she said, "It's always like you just don't talk about it." This is about sexual and reproductive health. It's one of those things that's left to the side. It's like healthcare providers feel it's not as important as everything else, but sometimes it is. I mean, it wasn't life or death threatening, but it could have changed my life a lot. And I almost always include this quote whenever I speak about this topic, because I think it's important to ground ourselves in the fact that, you know, this is something that is truly life-changing and extremely important in the comprehensive care of people with cystic fibrosis that we should be talking about. A survey we did a couple of years ago and some older work done among men with CF found that about 80% of people with CF intend to have future children. And I think when we think about people's reproductive goals, I want to be really clear as to what I mean when I say that. I think there's certainly this option for parenthood, and there are multiple ways to become a parent. And one of those is pregnancy for you or your partner. And there's also this idea of not becoming a parent, and that is your reproductive goal. So pregnancy prevention, and then it's important to consider birth control or contraception. there's been some work done around how to get at somebody's reproductive goals when you as a provider are talking with them in the clinic. And this is the question that I like to ask my older patients. And then when I'm working with adolescents, I often will frame it a little bit differently. So the question is, would you like to become a parent in the next year? And as I said, when I work with younger teens, I often say, would you ever like to become a parent? And I want to really lay out that there are 4 very valid responses to this question. There's yes, no, not sure, or okay either way. If somebody says yes, I often like to explore if they or their partner would like to become pregnant. And if that is a yes answer, then we really want to think about preconception care and possibly fertility counseling. If the answer is no, really going through the options of adoption, surrogacy, foster care, or step parenthood for the person. If the answer is no, and they're having penile vaginal sex, which would put them at increased risk for pregnancy, we really want to think about contraceptive counseling and go down that path. And then finally, there's these options of either uncertainty or ambivalence. And I think that those are can be very common feelings for both people with CF as well as the general population. And then I think it's really important that we're partnering with our patients and deciding how we can best support them as they think about this topic. So I want to talk a little bit about optimizing communication a little bit further. So in research that's been done, people with CF report that they often are not forthcoming about their reproductive plans because they don't want to disappoint their CF team. And this is something that has come up. This is not a direct quote, but it's a sentiment that's been brought up as I've been thinking about this alongside people with CF. And one woman shared it this way. She said, if I get pregnant, I'm seen as selfish for risking that my child will grow up without a parent. And if I prioritize my own health, I'm seen as selfish for not choosing parenthood and choosing myself. So this is complicated. Again, this is complicated. In surveys that we did among adolescent and young adult women with CF, we found that 72% of them were concerned that their future children may have CF. And then nearly 80% would elect to do genetic testing for CF for the future children. And just to review, if a person with CF decides to reproduce with someone who is not a CF carrier, 100% of their offspring will be carriers for CF and 0 will be affected with CF. But if someone with CF reproduces with someone who is a carrier for a mutated CF gene, 50% of their children will have CF, and then 50% will be a carrier. So when we think about genetic testing, this is really a personal decision to get genetic testing to find out if your partner is a CF carrier. Partner testing is usually done via a blood sample or an oral mucosal scraping, and it looks for just the most common CF mutations usually. And about 1 out of every 31 Americans is a carrier of a CF gene mutation. And you can see at the bottom of this page, the CF Foundation has some really nice resources around carrier testing for CF that I encourage you to check out if you have some questions on this topic. So I wanted to turn to the next part of the talk, which is around family building options. So as you can see, Parenthood sits in the middle here. And as you go around the circles, there are many ways to build a family. There's pregnancy, adoption, surrogacy, foster care, and step parenthood. And all of these options have been successfully pursued by people with CF. Just to review male fertility in CF, about 98% of men with CF are infertile, and this is due to congenital bilateral absence of the vas deferens. And this is really atrophy or absence of structures from the epididymis to the seminal vesicle. So you make sperm, but you can't get sperm out. So obstructive azospermia is the fancy term for that. you still produce sperm, and testicular histology, or when you look at it under a microscope, is usually normal. When we think about assisted reproductive technologies and options for males with CF, it's really about sperm being retrieved from different places within the male anatomy. So there's open surgical approaches kind of from the epididymis or from the testes where you undergo a surgery. Or there's the ability to use a needle through the skin and kind of suck out sperm from, again, the epididymis or from the testes. That harvested sperm can then be used to fertilize a partner's egg through intracytoplasmic sperm injection. And sorry, there's a missing parentheses there. About a third of people have success each cycle with this method. I wanted to highlight that there's a difference here between this process and what people tend to phrase as artificial insemination. In artificial insemination, you usually use donor sperm to fertilize partners' eggs, but it's done through the same process. But there is a slightly decreased success rate per cycle with that option. Let's turn over to female fertility in CF. And I can't underline this enough that most women with CF are fertile. The definition of infertility is the inability of a couple to conceive after 12 months of regular penile-vaginal sexual intercourse without the use of birth control. And this is among women less than age 35. That time frame drops down to 6 months in women 35 years and older. There's many causes of female infertility in CF, and I think that among a lot of the concerns are the fact that they may have decreased fertility due to recurrent infections, chronic hypoxemia, undernutrition, increased energy expenditure, chronic stress, or poorly controlled diabetes. But there's also more CF-specific concerns, meaning that there's defective CFTR, the CF protein, within the cervix. And this can promote production of a thick cervical mucus, which is dehydrated and can really block the opening of the cervix and impair sperm entry. There's also defective protein within the endometrium itself. And this alters the bicarbonate secretion, which can reduce uterine fluid volume, and it really just impairs the ability of sperm to fertilize eggs. So there's kind of two impacts of CFTR within the female reproductive tract that may contribute to subfertility. There's this idea that fertility may be positively impacted by highly effective modulator therapies. So by this, I mean Kalydeco or Tricafta. And I refer to this as HEMT here. And there's a couple reasons why this might be the case. The thought is it may generally, and we know these medications often generally improve health and nutrition, but it may also impact the cervical mucus thickness and improve the pH, or that bicarbonate secretion. There's been a look at this during the Kalydeco trials, where 2% of the women who were in the trial became pregnant during the trial itself. And there's been several case reports of unintended pregnancies in women on highly effective modulator therapy. There's also been cases of women who reported that they were previously infertile, and then they became pregnant after starting Kalydeco or Tricafta. So I think it's important if you are on one of these medications and do not desire to become pregnant and you're having sex, that you really want to consider making sure that you're on an effective form of birth control. So I wanted to talk about evaluation and management of female infertility in CF. So I think just like any woman, you really start by assessing ovulatory function, or the ability of an egg to migrate down into the female reproductive tract, and make sure that female reproductive anatomy is normal. There's a couple different fertility medications that are commonly used, And these really stimulate the ovaries to produce follicles with eggs. And sometimes these medications are used with intrauterine insemination, which can bypass that thick cervical mucus. IVF, or in vitro fertilization, is an additional option should these kind of less invasive treatments fail. And I wanted to end my part on a positive note, and the fact of that is that there's more coming soon on this. So I think that some of our knowledge around fertility and CF and around reproductive goals is really limited because there's not been a ton of work done in this area to date. But the studies that are listed here are things that are either in progress or hoping to be funded in the coming years. There's work going on around maternal fetal outcomes during pregnancy and cystic fibrosis. We're making a reproductive goals decision aid for women with CF. We're looking at contraceptive use in CF, the interplay of female sex hormones and CF health, the impact of these new highly effective modulators on cervical mucus. So do they really thin it out, and what's going on there? There's also work going on around urinary incontinence and other aspects of sexual and reproductive health, and hopefully work going on around parenthood and men's health in the near future. And I think with that, that was the last of my slides. I'm going to turn it over to Michelle, and she will take you through the next bit.
Thanks, Tracy. So as Tracy said, there's a lot that we haven't been capturing, and that work is ongoing. So I want to spend a little bit of my time just sharing with you our experience. So since we can't speak nationally yet, I'll just let you know what we've been seeing locally over the last 10 plus years that I've been here with the adult Northwestern program. So our experience so far has been that women, CF women that can become pregnant really at equivalent rates as their age match peers. So we do start to see issues just as we would see in older women in the community without CF. But really, we have not seen CF be a significant impairment with fertility and pregnancy for women. So we recommend for all of our women that are not ready to become a parent that they should be pursuing birth control measures until pregnancy is desired, just as Tracy had mentioned. In addition, all the men that our CF men that have attempted, we've traditionally used the MESA procedure with our urologists, have successfully fathered a child. So it is possible with several cycles at fairly high rates. So we encourage these discussions and talk about the options. We proactively discuss family planning and partner screening as indicated for those that are desiring pregnancies, but we also will discuss all family building options, as Tracy mentioned. Specifically at Northwestern, we have partnerships with our maternal fetal medicine. All of our CF women that become pregnant are high-risk pregnancies because of their underlying medical condition and need to have someone who's able to deal with any urgent issues to follow them. So we partner with MFM, as well as a local urologist who is very familiar with CF and performs our MESA procedures. We will say that pregnancy with CF does come with a risk of severe pulmonary exacerbation, has been the data up until recently. So we do discuss that this may have an impact on your respiratory health. Most of our patients looking back in our program and historical data has suggested that there will be an impact causing a severe exacerbation requiring IV antibiotics and or hospitalizations. We have opted to treat those events with single agent beta-lactams because the beta-lactams are our only pregnancy class B antibiotics that will cover Pseudomonas, which is highly prevalent in our adult CF population. This is different from how we normally approach our exacerbations. And next slide, please. So we had gone and looked in it a little bit more, and I'll give you that data in a second. So when patients come and say, we're thinking about a family, how do we approach that? The biggest issue is we talk about it, and we talk about it early. So when patients come to our transition clinic, we won't have a full-scale discussion, but we'll approach the subject. This is something we want to speak with you about. So this is something on our agenda, our timeline. When patients share that they're having engaged or life events, again, that's another opportunity for us to say, hey, let's have a discussion so that we're all informed and understanding what the options are and can make the best choice in conjunction with our patients. If pregnancy is desired or anticipated, we actually do recommend a full gene analysis. So if you send patients to their PCP for CF gene analysis, it's usually a shortened amount of genes that are analyzed. Traditionally, we've asked for a full gene analysis just so we can have a better understanding. So it may be a higher cost, we'll have a discussion, but that's been our practice here at Northwestern. Once pregnancy is confirmed or reported, again, all these patients are referred to our high-risk OBs, and then they're typically seen fairly frequently. So in the first trimester, maybe we'll wait between a couple months, but within the second and third trimester, we're usually seeing these monthly to assess weight check, spirometry, any nutritional needs that may be required. And we're touching base with their obstetricians just to let them know what we're seeing. When pregnancy has been confirmed, we'll also consider their chronic medications. And for the most part, they are continued throughout pregnancy. I'll let Alex speak to some of the medications considerations, but traditionally we will look at those in anticipation. Potentially when patients are seeking to become pregnant, we may make some alterations, but it's definitely a discussion that we'll have. As I mentioned, aminoglycosides are class D in pregnancy, so we have typically tried to avoid those just for the time of pregnancy, including inhaled. We may transition someone over to Caistin in lieu of their Toby during the time of pregnancies. But we do anticipate exacerbations, and again, our approach has been to use single agent beta-lactams during pregnancy compared to our standard multi-agent pseudomonal coverage. And we wanted to know, is that a good practice? And on our next slide, I'll show you a little data that we had pulled up. And this is fairly old data, but it gives you an idea of this is pre-modulators. This is the reality of what we were seeing back in the olden days of 2009, if you guys can remember that. But it's the data I had on hand and data I really want to share. And it's been similar to the experience that we were seeing. And I think it provides a good reference. So as you can see, we had 7 patients. We actually had 9 pregnancy events. One was including twins. And so we had 10 total births. Average age 25, ranged from 20 to 32. Our BMI was around 24. So we had a good BMI. Our average FEV1 going into this was 65%. So these are not patients starting off at 100%. These are 65% at the start. Some CFRD, all of our patients had pancreatic insufficiency, all of them had Pseudomonas. And the vast majority actually had, half of our patients had a traditional vaginal delivery. And almost all of them, I think, went full term. I think the one that was lower was actually the twins. So that is very good news and very reflective of what we would see in the general population. Next slide, please. So our question was, how does single agent therapy differ with pregnancy? Is this a problem? Are we challenging our patients? And what we saw is it really didn't change from our pre-pregnancy to our postpartum use of that single agent. We didn't see a drop in the postpartum period after doing that, which was really, really helpful. And also gives you an idea, for the vast majority of our patients, pregnancy didn't have a long-term impact, or at least a short-term impact on their lung function by using that single agent. Next slide. We also broke it down compared to their prior exacerbation responses versus single agent with just a beta-lactam versus a dual agent. This also showed that there was no significant change during their response during pregnancy versus their non-pregnant response. Next slide. And then the last was really what those long-term changes was. So we took a period of 2 years before pregnancy and a period of 2 years after, and we didn't see a drop in their FEV1. So this really was supportive to say, in the pre-modulator era, in women with moderate lung functions and good nutritional outcomes, we cannot see a significant change post-pregnancy, or we did not see a significant change post-pregnancy, at least in terms of FEV1. So it says that this can be safe. We highly follow our patients. We have a lot of discussions. Is this the right choice for you? And we'll walk them through the process. Next slide. So how do we approach family planning at Northwestern? Well, Tracy kind of talked about how she looks at it. And my first question is not in a great algorithm. I'm going to steal that. But we talk about, how do you want to have a family? What does that mean to you? Do you want to have a pregnancy? What are the options? We have literally had every option within our CF community, our CF patients that we follow here in terms of building a family. And so we like to bring out and note that every option is possible to you. What makes sense for you? And then if we say we want a family, really anybody, but if you're saying I want to have a family, then we say we need to really look at optimizing your lung function, your weight, and your sleep prior to consideration if you're going to carry a pregnancy. Just because we know that pregnancy and having children disrupts that whole thing. So optimization, really getting yourself on level footing, knowing that pregnancy is hard on any woman's body, but specifically a woman with underlying health conditions, trying to have that as our goal is optimal. We also will talk to parents, both our men with CF and our women with CF that are contemplating pregnancy. And I recommend seeking out support. So get that family support system, knowing that, when there is a child involved, it's really hard to do treatments. It's hard to get sleep. It's hard to do a lot of the personal self-care. So reach out and have it planned for ahead of time. Understand that this is going to be something that you'll need in addition to your normal needs, so that you can enjoy yourself, you can enjoy your children, and you can take care of yourself and your family, both in the short term, but for years to come. And then we always discuss questions or concerns, and we try to do it in a very collaborative, multidisciplinary healthcare team. That includes our CF team, including our dietitian, our pharmacist, but it also includes high-risk OB, our urologist, REI if that's required, and our patient's PCP. So it takes a village, but I think it's well worth it, and we're here to support our patients. And with that, I'm going to turn it over to Alex, our pharmacist, who will go over some of the medications for you all today.
Hi, thanks, Michelle. Let's turn to the subject of the implications of initiating or continuing CF medication regimens during pregnancy and lactation. Next slide. So let's start by reviewing the benefits of these medications. Like why do the docs want you to take the medications in the first place? So the modulators are a class of medicines that treat the underlying cause of CF. And from studies, we know that they improve the FEV1 and quality of life. They reduce the rate and frequency of exacerbations. And then the most recent addition, Tricafta, has been kind of a blockbuster. It's produced dramatic improvements, which have been observed, and especially with weight gain, and then associated improved nutritional status. And that has implications for the ability to continue lactation. The inhaled mucolytics, so pomazine and hypertonic saline, have been shown to improve FEV1 and quality of life and reduce exacerbation frequencies. And the inhaled antibiotics, when indicated, have been shown to reduce the exacerbation frequency, the number of hospitalizations, as well as improve quality of life. Next slide. For azithromycin, which is indicated for people who have positive sputum cultures and chronic lung infection, chronic azithromycin therapy has been shown to reduce exacerbations, reduce the number of courses of antibiotics that patients get, as well as improve FEV1, and a little bit of weight gain has been associated with that. And then pancreatic enzyme replacement therapy for patients who are pancreatic insufficient improves nutritional status, which helps patients maintain a healthy BMI, which has been associated with better outcomes. So the use of medications in pregnancies presents challenges. So the FDA used to place meds into 5 safety categories based on the level of evidence that was available. But the major criticism of this is that it led to a little oversimplification and made the risk-benefit conversation with providers difficult. For example, 60% of all medications are category C. And this really doesn't address the issue of stopping the medication that is needed or going without the medication. Next slide. So the new system removes the letter categories and provides a summary of the human and animal data that's available. Here's an example of the pregnancy safety information from Pulmozyme. So pharma companies are required by the FDA to do animal testing, and then data in humans come out after the medication's been approved. And this is actually meant to facilitate the risk-benefit conversation with the provider. Next slide, please. So Ivacafta was the first CFTR modulator approved. When it was studied in animals, no harmful effects were noted at the maximum recommended human dose. And there is data available in humans. There's a paper that looked at 31 pregnancies, and no Ivacafta-related pregnancy complications were reported, and no adverse infant effects were reported. And it is excreted in breast milk. Data from 13 infants showed no complications. And I have a graph here on the side, which I think is really interesting. This is from a case report that actually looked at maternal plasma levels and breast milk and levels in breast milk, as well as infant plasma levels. And so on day 0, that would be the date of birth. You can see that the black triangle at the very top is the concentration of Ivacafta that's in the umbilical cord, the blood in the umbilical cord. And then the black square at the bottom is the concentration of the Ivacafta in the infant. And so that it's just one patient, but it's a good illustration of just what a small, tiny fraction actually makes it to the patient or to the infant. And then there's also a line with the triangles that shows the breast milk concentrations. And it does a good job of, I think, showing the relationship between the concentration of the Ivacafta in mom's blood, and then what makes it into breast milk, and then what makes it into the infant once they get the breast milk. And so it is, in the case of Ivacafta, a very small amount. Next slide, please. The Orkambi was the second approved modulator. It's got Ivacafta. All of the modulators actually have Ivacafta in them. This is in animal data shows that no harmful effects were noted at the doses that are higher than the maximum human dose, recommended human dose. And info we have from 26 pregnancies shows that there were no Orkambi related pregnancy complications. There were 2 maternal complications. That one was a pulmonary exacerbation, which is not a surprising thing. And then the second was a postpartum diagnosis of AML, which is very unusual. It's not really reported with Orkambi, and it's questionable if it's related to Orkambi, but they did note that in the paper. And there were no adverse infant effects noted. Orkambi is excreted in the breast milk. We have info from 9 infants that were breastfed on it, and there's no reported complications. And then there's a separate case report that came out that showed the infant had elevated LFTs, which ended up resolving without complication. Next slide. Symdeko is prior to Tricafta, the second most common or most frequent or most recently approved modulator. It's kind of a theme with the modulators. Data from animal studies show that there are no harmful effects at doses that were studied that were above the maximum recommended human dose. We have info from 7 pregnancies that show no pregnancy complications and no infant adverse effects, and breastfeeding data from 5 infants, which show no adverse infant effects. And Tricafta is the star of the show for the modulators. It's a fantastic drug. This is animal data shows that it's safe at doses. There were no effects noted at doses that were greater than the maximum recommended human dose. We have info from 47 pregnancies. And I think it's a good time to just revisit that pregnancy has inherent risks and that there is just kind of a background risk for certain things of happening. For example, there's a 2 to 4% fetal malformation birth defect rate and a 15 to 20% miscarriage rate. So the miscarriages that were observed were not unusually high. There was one that resulted in fetal malformation, but that's unknown if it was the Tricafta related. There were 2 possibly Tricafta related pregnancy complications. One's cholecystitis, which is something that's starting to be reported with Tricafta, and then obstetric cholestasis. Premature births were noted, but they weren't thought to be related to Tricafta, and there were no infant or Tricafta related infant complications. We do have info from 26 infants and they're who were breastfed with mothers taking Tricafta, and there's no complications reported. So azithromycin has been around long enough that there's been a fair amount of information published. The animal data shows that there's no harmful effects at doses greater than the maximum recommended human dose. In the FDA labeling, they state that there's no increased risk to humans. And then there was a paper published after that product labeling was updated, so that the most recent product labeling for azithromycin was 2019, and this paper was published in 2020. And they looked at all of the most recently published studies with azithromycin in pregnancy and found either no risk or a small increased risk. And then it is excreted in breast milk, but there's been no serious adverse events noted, and that patients who are infants who are breastfed with mothers taking azithromycin, it's recommended to monitor for diarrhea, vomiting, and rash. And pancreatic enzyme replacement therapy is not really absorbed, so you don't get blood levels. So there's not really infant exposure with enzymes. Next slide, please. And then the inhaled therapies do not really get appreciable systemic absorption. And so there's very little risk to the fetus continuing the pulmozyme or continuing the inhaled therapies. And with that, I'm finished and we can open up to questions.
That one more presentation. Check Q&A in the chat to see if we have any questions coming in. These if you do have a question, use the Q&A feature to submit questions. We did have a few that submitted online. The first question came up was I found out we'll see what we do next presentation.
Hey, David, it's Meg. You're cutting in and out, so I'm not sure that anyone can hear the question, what you're saying.
Sounded super cool, David.
Yeah, you sound like Darth Vader.
Glad somebody said something. I thought I was so worried.
Maybe try and mute and unmute again. No.
If anyone wants to put a question in the chat, we can look at that.
Or David, if you have some of the questions, if you want to type them in the chat, I'll read them for you.
I can see that Seth had a comment about carrier testing and moving away from carrier testing by common mutations, and I can't underline this enough. This was actually brought up during the ResearchCon diversity symposium, because I think that what we determine as common mutations, what's common for, you know, one race or ethnicity is not necessarily common for another. So I think that we really just need to be moving away from it. So I completely agree.
So the first question is, my daughter's first child was born with CF. What can we do to ensure the next child won't have it?
So I can speak to this. I think that there's a couple options that people can consider in this scenario. One is if a pregnancy has already occurred through amniocentesis or other kind of sampling strategies, you can test the fetus for CF prior to birth and then make a decision based on that. The other option is to consider pre-implantation genetic testing. And in that scenario, you really can, it's coupled with in vitro fertilization. So I think there's some cost considerations accompanied by that. But then you can test those embryos for CF prior to implantation to assure that the next child won't have CF.
Thank you. The next question was, how many children can a person with CF have?
I'll take that one. As many as they can handle is probably the best option. So I don't think there's necessarily a limit. I think it's a self-implied limit for a lot of reasons. And I don't think CF has ever really been that question mark about, you know, family planning as much as, you know, we may consider, you know, how they reacted to prior pregnancies in terms of, you know, their weight, their lung function, and their comfort level with that. But that is no different from any other woman with any other pregnancy. And so if there are issues or concerns that may impact a woman's choice to expand their family beyond a certain number, but there's no absolutes in that other than the logistics of just having big families. And so that's a personal preference, but it's usually in discussion with their providers in terms of how they did, how they feel, a lot of logistics, but there's no absolute ceiling.
Thank you. Does anyone else have any other questions? I don't see any in the Q&A section. So thank you all for presenting today. We really appreciate your time and insight into this topic. And thank you all for those of you who joined us. We really appreciate it and hope you were able to get some information out of this presentation. And this will be recorded and we will send it out afterwards as well. But thank everybody for their time and enjoy your weekends.
Thank you, everybody.
Thanks,
Thanks,
everyone.
guys.
Now, David, you're fine now.
Of course. Thank you, everybody.